My name is Tim Rosenberger, and I'm a science intern entering my senior year at Lutheran High School West. This summer, I worked in cardiovascular medicine with my mentor, Dr. Fetnat Fuad Tarazi, examining patterns of blood pressure and heart rate response to TIL test in relation to anxiety symptoms. I identified the following terms as essential to an understanding of this project. Beck Anxiety Index, or BAI, a metric of anxiety severity that looks at 21 symptoms of anxiety, each graded on a 4-point Likert scale. Classical POTS meets all criteria for POTS, see below, and occurs within first 10 minutes at 70 degrees of head-up tilt test. Head upright tilt test, or HUT, records blood pressure and heart rate on a minute-by-minute basis while table is tilted in a head-up position at different levels. Postural orthostatic hypotension, or POH, a drop of 20 millimeters systolic or 10 millimeters diastolic blood pressure during the head-up tilt test. Postural orthostatic tachycardia, increase in heart rate of at least 30 beats per minute above baseline or above 120 beats per minute upon HUT. Vasodepressor response, or VDR, a sudden drop of systolic blood pressure and or diastolic blood pressure without a concomitant drop in heart rate. Vasovagal response, or VVR, sudden drop in heart rate, systolic blood pressure, and diastolic blood pressure with symptoms such as nausea or dizziness. My primary objective was to examine the relationship between time to postural orthostatic tachycardia syndrome and severity of anxiety symptoms. My secondary objectives were to determine types of syncope-related disorders in patients with anxiety symptoms, and to examine the characteristics of the head upright tilt test for patients with histories of syncopal episodes and documented anxiety symptoms. I began with the following hypothesis. The time to POTS correlates inversely with anxiety severity in patients undergoing the head-up tilt test. To examine my hypothesis, I examined patients presenting to the syncope clinic for head upright tilt test and asked them to complete a survey prior to their visit. Patients underwent the head-up tilt test to detect instances of POTS and other syncope-related disorders. Patients completed the Beck Anxiety Index prior to undergoing the head upright tilt test. Head upright tilt test results were examined to determine instances of POTS, time to POTS, and other significant syncope-related disorders. Mean Beck anxiety scores for each symptom were tested for statistical significance. I discovered the following data. 28.6% of my patients were males. 71.4% were females. The mean age for those patients was 39 years. Patients were predominantly Caucasian. Psychiatric data was analyzed with the Beck Anxiety Index. Most patients fell into the mild to moderate ranges, while significantly less patients reported minimal or severe anxiety symptoms. The data led to the following results. Numerous scatterplots showed virtually no statistical significant correlation between anxiety symptoms and any of the syncopal events that I studied. The following correlation coefficients also showed no link between syncope and anxiety. I did, however, find that patients with classical POTS had significantly more severe anxiety symptoms as measured by Beck Anxiety Index compared to patients not exhibiting classical POTS. I drew the following conclusions. Contrary to our hypothesis, there is no correlation between time to POTS and the severity of anxiety symptoms as measured by the Beck Anxiety Index. There was no statistically significant difference in mean Beck Anxiety Index scores between participants with and without classical POTS. Most patients reported anxiety symptoms according to the Beck Anxiety Index. The mean Beck Anxiety Index score for patients included in this population was determined to be 14.67, which would be considered a mild level of anxiety symptoms in a standard population. The mean of Beck Anxiety Index scores for patients presenting with each of the symptoms failed tests for statistical significance. Mean BAI scores for patients presenting with each symptom were compared to the rest of the population. Patients with classical POTS had a BAI score of 17.65, while the mean of all other patients was 14.02. A series of student t-tests were used to test for statistical significance between instances of syncopal symptoms and heightened BAI scores. They showed there was no statistical significance between the two factors. My project led me to make the following recommendations. Patients with previous diagnoses of anxiety symptoms should, in general, not be treated differently when undergoing the head-up tilt test than patients without such diagnosis. Physicians may consider autonomic disorders, especially classical POTS, when treating patients who present with uncommonly high BAI scores. Future analysis should examine the impact that anxiety-reducing medications and other treatments may have on patients' responses to the head-up tilt test and answers to questions on the BAI. My photos came from the following sources. I would like to thank my fellow authors, especially Dr. Kathleen Franco, my mentor, Dr. Fetnat Fuad Tarazi, Linda Saju, Dr. Sam Wheatus, and everyone else in the Syncope Clinic and the Office of Civic Education that made my experience this summer amazing. Thank you.